Hey everyone, this presentation is on intestinal and rectal disorders. Here are some objectives that we wanted you to be able to take from this presentation, but essentially we wanted you to know the manifestations, the description of the disorder itself, and some treatments and medications. So I'll just go through these so that you can write them down.
Okay, so we're just going to start out with some basic anatomy of the intestinal tract. The intestines are a long, continuous tube stretching from the stomach to the anus. And that includes the small intestine, large intestine, rectum, and the appendix. The small intestines lie between the stomach and the large intestine, and that includes the duodenum, jejunum, and ileum. Most water and nutrient absorption occurs in the intestines, specifically the small intestine absorbs most of the nutrients from what we eat and drink. The large intestine is the terminal part of the intestinal tract, and that includes the cecum and colon. And the main function of the large intestines are converting food into feces, reabsorbing water from feces, and absorbing essential vitamins. The appendix itself is a small finger-like appendage about 10 centimeters long that's made of lymph tissue, and it's attached to the cecum just below the ileocecal valve. And there are just some pictures just pointing out what I just explained.
The patho of constipation is an interference of mucosal transport, myoelectric activity, or the process of defecation. The clinical manifestations include less than 3 bowel movements per week, abdominal distension, pain and pressure, decreased appetite, headache, fatigue, indigestion, feeling like there is incomplete emptying, excessive straining, and the elimination of hard and lumpy stools. The complications are hypertension, fecal impaction, hemorrhoids, fissures, and a megacolon. Medical management includes education, exercise, bowel habit training, increased fiber and fluid intake, and a safe use of laxatives.
Okay, diarrhea is the increased frequency of bowel movements, the amount of stool produced, and an altered consistency. It can be either acute, which could be caused by an infection, or chronic, which could be caused by anything from medications, tube feeding formula, or endocrine disorders. Clinical manifestations include the increased frequency of defecating, increased fluid content of stools, abdominal cramping, distension, gas movement through the intestines, anorexia, and thirst. Complications that are possible include cardiac arrhythmias due to significant fluid and electrolyte loss. Loss of bicarb can lead to metabolic acidosis, decrease in urinary output, muscle weakness, paresthesia, hypotension, anorexia, drowsiness, and contact dermatitis from wiping so often. Medical management is directed towards controlling the symptoms and preventing complications and eliminating or treating the underlying cause.
Fecal incontinence. The patho includes many things such as underlying conditions, trauma, neurologic disorders, inflammation, infection, chemotherapy, radiation treatment, fecal impaction, pelvic floor relaxation, laxative abuse, medications, or advancing age. The clinical manifestations are minor soiling, occasional urgency, loss of control, or complete incontinence. The complications include possible skin breakdown, urinary tract infections, and a loss of dignity. Medical management is not really possible with fecal incontinence. However, there is an underlying cause, and treating the underlying cause could make the fecal incontinence disappear.
Okay, irritable bowel syndrome. Pathophysiology is a result from a functional disorder of intestinal motility. The clinical manifestations range from mild and frequent to severe and continuous. Main signs include an alteration in bowel patterns, constipation, diarrhea, pain, bloating, and abdominal distension. The complications are malnourishment and decreased quality of life because avoidance of certain foods is necessary to maintain full daily functioning. And medical management goals are to relieve abdominal pain, controlling diarrhea or constipation, and reducing stress. Okay, the next thing we're going to go over is malabsorption. And that is a deficiency in the digestive system to absorb any major vitamins, minerals, or nutrients. And that most commonly occurs in the small intestines. There are 5 categories that cause malabsorption: mucosal infectious diseases, luminal, post-op, and specific nutrient disorders. And you can kind of read over those yourselves. Manifestations. The generalized manifestations of malabsorption are diarrhea, steatorrhea, which is frequent, loose, bulky, foul-smelling stools, and that has an increased fat content, so it's a different kind of color. It's a grayish color. Patients exhibit abdominal distension, pain, increased flatus, weight loss, and weakness. Other symptoms include osteoporosis, anemia, and bruising. If malabsorption goes untreated, patients will become emaciated due to starvation and dehydration. So the treatment targets supplementing lost nutrients and avoiding diets that would aggravate the malabsorption. Depending on the cause, interventions will actually vary. And vitamin supplements are a big one. Dietary changes for celiac disease, antibiotics, and surgical procedures if there's tumors.
Okay, so for appendicitis, it's actually when your appendix becomes inflamed. Your appendix is lymph tissue, and sometimes lymph tissue does not drain, and it becomes enlarged. And that's what happens in an appendicitis. And so about 24 hours after the onset of pain, perforation of the appendix can occur. Perforation of the appendix can lead to peritonitis, abscess formation, or portal pile phlebitis. Some treatments are, if the appendicitis is mild enough, it can be treated with an antibiotic. If it is not mild, you have to have surgery. You can have it open surgery, or you can have it laparoscopic. They do give IV fluids and antibiotics before the surgery. And an abscess may be drained before the surgery if perforation occurs. These are just some of the symptoms. I'm not going to go through all of them because it is a long list, but basically there's vague epigastric pain that increases in strength and localizes in the right lower quadrant. Tenderness at McBurney's point with pressure may be present. A low-grade fever, nausea, loss of appetite, some rebound tenderness, depending on where your appendix is actually located, because sometimes it can be a few different areas, obviously in the same region, but not always right where it's supposed to be. And also you can have pain upon defecation and urination.
Okay, diverticular disease. Just going to go through these. Diverticulum is like a sac-like herniation of the lining of the bowel that extends through a defect in the muscle layer. Diverticulosis is when multiple diverticulae are present without inflammation or symptoms. And then diverticulitis occurs when there's food or bacteria retained in those diverticulum, and that's what causes inflammation and infection. So those form when the mucosa and submucosal layers of the colon herniate through the muscular wall due to high pressure and decreased muscle strength in the colon wall. And the trapped contents in those herniated spaces decompose, causing inflammation and infections. Some manifestations: chronic constipation, bowel irregularity, diarrhea, nausea, vomiting, anorexia, bloating, distension, fever, and leukocytosis. Abscesses, fistulas can form, obstructions, perforation, peritonitis, and hemorrhaging can occur if it's severe. And then you'd have mild to severe pain in the left lower quadrant with that. Treatments include a clear liquid diet, rest, analgesics, antispasmodics. You want a high fiber, low fat diet, antibiotics, bulk forming laxatives, NG suctioning and stool softeners. And then you would have surgical interventions in some acute cases, which would be like a bowel resection.
Peritonitis is inflammation of the peritoneum, the serous membrane lining the abdominal cavity and covering the viscera, caused by leaking of contents from abdominal organs into the abdominal cavity, usually as a result of inflammation, infection, ischemia, trauma, or tumor perforation, and also in appendicitis. Bacterial proliferation occurs, edema and exudation of fluid develops in a short time, resulting in hypermobility of the intestinal tract and possible paralytic ileus. Some manifestations are diffuse pain, so pain with movement, tenderness, distension, rigid muscles, rebound tenderness, paralytic ileus, nausea, vomiting, anorexia, increased temperature, increased pulse and hypotension, and increased white blood cells. And that is a lovely picture of peritonitis. And some treatment is fluid, colloid, and electrolyte replacement, analgesics, intestinal intubation, and suction.
Okay. Inflammatory bowel disease. Chronic inflammatory GI disorders include Crohn's and ulcerative colitis. And a positive family history is the largest independent risk factor. But there's also environmental agents that they think may trigger IBD, and that's pesticides, food additives, tobacco, and radiation. Okay, so we'll start off with Crohn's disease. And Crohn's disease is a subacute and chronic inflammation of the GI tract wall that extends through all of the layers. Onset of symptoms is usually insidious with prominent right lower quadrant abdominal pain and diarrhea. Abdomen tenderness and spasms, pain after meals, weight loss, malnutrition, ulcers, and steatorrhea. And then abscesses, fistulas, and fissures are common. Treatment would include corticosteroids, antibiotics, a different diet, TPN, partial or complete colectomy with an ileostomy, or a bowel resection. Okay, and then we have ulcerative colitis, which is recurrent ulcerative and inflammatory disease of the mucosal and submucosal layers of the colon and rectum, which includes ulceration, diffuse inflammations, and shedding of the epithelial cells of the colon. Bleeding often occurs due to ulceration and lesions that actually occur one after the other, beginning in the rectum and spreading proximally to involve the entire colon. And abscesses form and infiltrate as seen in the mucosa and submucosa, with clumps of neutrophils found within the lumen. Eventually, the bowel narrows, shortens, and thickens because of the muscular hypertrophy and fatty deposits. And that can be classified as mild, severe, or fulminant.
Okay, so manifestations of ulcerative colitis are diarrhea, passage of mucus and pus, left lower quadrant abdominal pain, rectal pain, anorexia, hypocalcemia, anemia, and some cramping. If it gets too bad, you will get toxic megacolon or some perforations. Some treatment can include fluids, low residue, high calorie diet, vitamin supplements, IV therapy for fluid and electrolyte imbalances, some TPN, foods that exacerbate diarrhea. So if the person is lactose intolerant, they shouldn't be drinking milk. Cold foods and smoking. Some medications that can be used are just some sedatives, anti-diarrheal medications, anti-peristaltic, anything for inflammation like corticosteroids and other things.
Okay, intestinal obstructions. An intestinal obstruction is a blockage that prevents normal flow of intestinal contents. And there's two different kinds. There's mechanical obstructions, and that is when they're caused from pressure on the intestinal wall. So if there's tumors or stenosis. Functional obstruction is when the intestinal musculature cannot actually propel the contents along the bowel. And there's several disorders that can cause that. Can be partial or complete, and the severity actually depends on the region affected, degree of the occlusion, and how much vasculature is disturbed. Small bowel obstruction is when the contents of the small bowel accumulate above the intestinal obstruction, causing distension and pressure, which increases, resulting in edema, necrosis, and eventual rupture. And reflux vomiting may be caused by abdominal distension, leading to possible acidosis. Some clinical manifestations include cramping, blood or mucus with no fecal matter or flatus, vomiting, and dehydration. And actually, the lower the obstruction, the more abdominal distension. Diagnosis is based on symptoms described and on imaging studies. So you can do an X-ray or a CT. And you would want to decompress the bowel with an NG tube. And you would want to do surgery in the presence of necrosis. So that'd be a bowel removal or reparation of a hernia. Nursing management, maintaining the NG tube, assessing for fluid electrolyte imbalances, and monitoring nutritional status. Large bowel obstruction would be the accumulation of intestinal contents, fluid and gas proximal to the obstruction, which leads to severe distension and perforation. If the blood supply is cut off and necrosis ensues, the condition becomes life-threatening. And clinical manifestations differ from small bowel obstructions in that the symptoms progress much slower. So constipation may be the only symptom for months, with stool gradually increasing in size. Blood loss in stool may cause iron deficiency anemia, weakness, weight loss, anorexia, and eventual marked distension of the abdomen with loops of large bowel becoming visible. And assessment is made, or diagnosis is made based on symptoms and, again, imaging studies. And you would want to correct the electrolyte imbalances. Colonoscopy can be performed if you need to untwist and decompress the bowel. And then you can also do a temporary or permanent colostomy. And then you just want to monitor for worsening symptoms and administer fluid and electrolytes as prescribed.
Okay, so next up we have colorectal cancer, and this is cancer of the colon and rectum, which is predominantly adenocarcinoma. It could start with a benign polyp and then turn malignant. Some manifestations are symptoms that are determined by the location of the tumor size, the stage of the disease, and the function of the affected intestinal segment. Some changes in bowel habits, and passing stools containing blood. Some other findings could be unexpected anemia, anorexia, weight loss, fatigue, abdominal pain. Basically anything that changes in your bowels, you need to keep an eye on and report to your doctor. Some treatments would be depending on the stage of the disease. Some other medications could be chemotherapy, radiation, immunotherapy, some herbs that would help with nausea, antiemetic medications, some IV fluids, and some NG suctioning. Some surgeries could either be curative or palliative. You could have a segmental resection, pretty much any type of colostomy or ileostomy as well. And these are polyps of the colon and rectum, and a polyp is a tissue that protrudes into the lumen of a bowel. It can be neoplastic or non-neoplastic. The neoplastic are actually more common in males than women, and non-neoplastic are benign epithelial growth. Some manifestations obviously depends on the size of the polyp and the amount of the pressure that it is pushing on the other walls. Most common symptom is rectal bleeding. Lower abdominal pain is also associated with a polyp. If polyp is large enough, an obstruction could occur. Some treatments would be to surgically remove the polyp via colonoscopy, laparoscopic, or colonoscopic excision. Microscopic examination identifies the type of polyp.
Okay, so we're going to move on to diseases of the anorectum. And these are common and occur in a majority of the population. And you would usually see a provider because of pain, rectal bleeding, or a change in bowel habits. These are things like hemorrhoids, anal discharge, perianal itching, swelling, tenderness, stenosis, and ulceration are more common complaints. So anorectal abscess is an obstruction of an anal gland, which occurs from dried debris, and it results in a retrograde infection. It's more common in patients who are immunosuppressed, and foul-smelling purulent drainage is common. You would also have some swelling, redness, and tenderness. And just for treatment, you would do a sitz bath, analgesics. Some cases you would want to incise and drain the abscess.
Next, we have an anal fistula, a small tubular fibrous tract that extends into the anal canal from an opening beside the anus in the perianal skin. Some causes are infection. They could occur from trauma, fissures, or Crohn's disease. 25% of Crohn's disease sufferers will actually probably develop a fistula. Some manifestations are purulent drainage, stool leakage, passing of flatus or feces from the vagina to the bladder, which obviously will depend on the location of the fistula tract, and if left untreated, the patient may show systemic infection symptoms. Some treatments are antibiotics and or anti-inflammatory type agents. A fistulectomy, which is actually an excision of the fistulous tract. The lower abdomen is flushed with prescribed enemas, and then the fistula is either dissected out or laid open by an incision from its rectal opening to its outlet and then packed with gauze. Anal dilation under anesthesia may be required, and also a lateral internal sphincterectomy could happen. Some other treatments that may increase healing and decrease pain those would actually increase healing and decrease the pain by increasing the blood supply, and it will relax the anal sphincter for chronic fistulas. Perianal or intraanal application of nitroglycerin ointment, calcium channel blockers, and some Botox injections will help with that. Next, we have an anal fissure, and that is a longitudinal tear or ulceration in the lining of the anal canal. Some causes are trauma of passing a large stool, firm stool, childbirth, overuse of laxatives, and persistent tightening of the anal canal because of stress and anxiety, which can lead to constipation. Some manifestations include painful defecation, burning, bleeding. Bright red blood may be seen on toilet tissue after a bowel movement. Some treatments would be that most will heal with a diet modification, so you need to increase your fiber either by a supplement or a lot of fiber in your diet. Stool softeners and bulk agents. Increase water consumption. Sitz baths, and emollient suppositories. Suppositories containing anesthetics and corticosteroids will actually help relieve discomfort.
Okay, next we have hemorrhoids, and they are dilated portions of veins in the anal canal. Causes during pregnancy, the increased pressure in the hemorrhoidal tissue can initiate hemorrhoids or aggravate existing ones, and straining while having a bowel movement can also cause hemorrhoids. Symptoms include itching, pain, bright red bleeding with defecation, and there are both external and internal hemorrhoids. External may cause severe pain from the inflammation and edema caused by thrombosis, and this can lead to ischemia and eventual necrosis. And internal hemorrhoids typically do not cause pain until they bleed, prolapse, or become enlarged.
Okay, some classifications of hemorrhoids are first degree. They do not prolapse or protrude into the anal canal. Second degree would be prolapse outside the anal canal during defecation, but they actually reduce spontaneously. Third degree would be prolapsed into the extent that they require manual reduction. And fourth degree would be prolapsed into the extent that they may not be reduced.
Some relief and treatments for hemorrhoids include good personal hygiene. You'd want to avoid excessive straining during defecation. Incorporate a high residue diet that contains fruit and bran, and increase fluid intake. Hydrophilic bulk-forming agents such as psyllium are good. You could also use warm compresses, sitz baths, analgesics, and suppositories, etc. Also, infrared photocoagulation, bipolar diathermy, laser therapy, and injection of sclerosing agents is effective for small bleeding hemorrhoids. These all help with preventing prolapse. Surgeries, they have rubber band ligation, cryosurgical hemorrhoidectomy, etc., etc. Okay, sexually transmitted anal rectal diseases. There are 3 infectious syndromes that are related to STIs, and that would be proctitis, which involves the rectum, and it's usually a result of anal receptive intercourse with an infected partner. Proctocolitis involves the rectum and the lowest portion of the descending colon, and enteritis involves more of the descending colon. And then just some symptoms that go along with those would be like watery, bloody diarrhea, cramps, pain, bloating, and weight loss. And to form a diagnosis, a sigmoidoscopy is most likely performed, and that would identify the portions of the anal rectum involved. And then you can use rectal swabs to identify the pathogens. And you could use, depending on the type of pathogen, you'd use antibiotics or antivirals, or something like metronidazole.
Okay, last on the list we've got is the pilonidal sinus or cyst. It is found in the intergluteal cleft on the posterior surface of the lower sacrum. 2 theories on how they are formed are: one is that is the result of local trauma causing penetration of hairs into the epithelium and subcutaneous tissue. And number 2, that they are formed congenitally by an infolding of epithelial tissue beneath the skin, which may communicate with the skin surface through one or several small sinus openings. Some manifestations are that they typically don't cause any symptoms until adolescence or early on in life. When infected, it produces an irritating drainage or an abscess. Perspiration and friction easily cause irritation to the area. Some treatments are in the early stages of the infection. It can be controlled with an antibiotic, and if an abscess is formed, surgery is needed. And for the surgery, they just do an incision and drain under local anesthesia, and then after the acute process is healed up, they'll do another surgery to excise the cyst and secondary tracts. And thank you. We have a funny little joke, and it says, "Did you hear the joke about the small intestine? It was very funny." Thank you.